May I call Dr. Prakhar Jain, sir, on the stage, please?
करना है कि तो यूज करना है हेलो Hi everyone, hello, all my colleagues. I'll not take a lot of time, but I'll over the time you will understand how cannabidiol and cannabis products are upcoming in the management of mental health disorders. This is one of the common scenes you'll always find in Thailand when you're moving around the cities. This says something about how cannabis is viewed in society right now. Interestingly, the entertainment industry has found more ways to use cannabis than doctors. If you can see what all is mentioned over this, they have found out how much percentage each of their items in their menu cards have THC, CBD. They have also found out which product will cause what effect relaxed, sleepy, hungry. Then you will find energetic, uplifted, creative, euphoric, talkative. And I can tell this is not just for sake of mentioning on the menu card, but I have talked to a lot of people who use these products in Thailand, and they actually feel these effects. This thing tells us that how cannabis as a molecule is very powerful, but very underutilized in our clinical practice. What I'll do right now is I'll just take some time to explain how cannabis works in our brain. It might take, it might be a little difficult because of the complexity of this molecule, but I would really like to present that. And why we need to talk about cannabis right now is we have been using monoamines like serotonin, dopamine modulators, and we have always found out that these molecules have some residual effects. The patients are not completely cured. They do experience side effects. They do ask us, sir, कितने दिन और लेना है? क्या ये lifelong है? And these all things do matter a lot to a patient, and this is why a new mechanism of action which we have always overlooked, we have never studied in depth, is the endocannabinoid system. The endocannabinoid system helps us understand which other molecules actually take part in the treatment of a depression or an anxiety patient. So this is the roadmap of the presentation. I'll just skip that. Talking about endocannabinoid system, so there are receptors in the endocannabinoid system, the CB1 and CB2. They are ligands, which are the molecules which will bind to these receptors. And these are enzymes FAAH and MAGL, which will terminate the actions of the endocannabinoids. So, what endocannabinoid mean is that there are certain molecules in our body which actually activate the cannabinoid system already. Before we used plants, the cannabis plant for mood modulation, the body was already producing these chemicals. I'm sorry for this slide, but the next few slides will be a little cluttered, but will be comprehensive enough to understand the roles of each receptors. So talking about CB1 receptor. CB1 receptor is the main receptor which is located in the CNS. If you understand and see here, where are these CB1 receptors located? So the high affinity of CB1 receptors are present in the cerebral cortex, amygdala, nucleus accumbens, hippocampus, basal ganglia, and there are other areas where these receptors are present, but which are not much of relevance to us. But these areas are exactly precisely the parts of the brain where we want to focus and target. So in cerebral cortex, it will be involved in cognition, memory, mood. In amygdala, it will be involved in emotion, fear, anxiety. Nucleus accumbens, reward, motivation, addiction. In basal ganglia, there will be control of motor habits, habit formation, reward processing. So all these areas are precisely where we want our patients to improve, and these are the areas where CB1 receptors are highly abundant and in high, they have a high affinity toward these receptors molecules. What effects these receptors cause once they are activated is you can understand mood and anxiety regulation, reward and addiction monitoring, appetite stimulation, pain modulation, neuroprotection. So the CB1 receptors are exactly those receptors where we want to improve our patient's health. Talking about CB2 receptors, CB2 receptors are commonly placed in immune cells, bones, spleen, reproductive organs. So basically, CB2 receptors are those receptors which are not concerned with the CNS, or we don't want these receptors to be modulated for our patient's recovery. However, CB2 receptors have gained considerable importance in cancer research, in pain management, where these molecules have been approved right now. Talking about the ligands, the AEA, the anandamide, and the 2AG system. AEA is the anandamide, is the main molecule, the star molecule which we want to talk today. Anandamide, the word has been derived from a Sanskrit word anand, and it's very interesting how it works and where it is located. So basically, anandamide is a molecule which is generated as per need, and it is destroyed immediately by a molecule called FAAH. What roles it plays? It has a very high affinity on the CB1 receptor. CB1 receptor was the one where we as a psychiatrist were very interested. Anandamide stimulates in a partial agonism format the CB1 receptors, and thus it causes improvement in memory, learning, executive function, attention, anxiety, fear extinction, appetite, stress response, reward, and motivation. The only problem is anandamide is destroyed immediately as it is released. Anandamide not only affects the CB1, it also binds to CB2 but with a low affinity. Interestingly, it has other actions like TRPV1, PPAR, GPR5. These are the areas which have a co-modulation effect in the overall effects of cannabis. The second molecule, which is 2AG, this is the molecule which is also an endocannabinoid, which means that it will be produced by the brain cells. This has a slightly longer half-life than the anandamide. However, it is a full agonist instead of partial agonism of both CB1 and CB2. The only difference is that 2AG is not as abundantly available in prefrontal cortex, amygdala as the anandamide. So 2AG is precisely an endocannabinoid but not with a lot of help to a psychiatrist. Now talking about what happens in a cannabis plant. What does a cannabis plant contains? So a cannabis plant will have certain terpenes inside it. Terpenes mean the characteristic taste or a flavor which we feel when we smell a cannabis. So there are different kinds of flavors, like limonene will have a flavor of lemon. Similarly, there are certain cannabinoids. We are very well aware of CBD and THC as the main cannabinoid, but there are more than 150 cannabinoids and overall more than 450 other compounds in a cannabis plant. The other cannabinoids, THCA, THCV, CBN, CBG, all of these have very significant role in mental health. Talking about the phytocannabinoids, what does it mean is a cannabinoid which is consumed externally. It is not the ones which are produced inside the body. And what phytocannabinoids mean is the THC, which is the tetrahydrocannabinol, CBD, cannabidiol. These are all external from the body, which is intake, which has to be taken externally. CBG, CBC, CBN, THCV. We will go in detail about THC and CBD, but I also want to bring your attention to the under-researched and under-developed molecules, which are CB1 and CB2 agonists, and can have a very significant role in future of psychiatry. So going forward with CBD. So CBD, as we all think, works by acting on CB1 receptors and CB2 receptors. But this is the biggest misconception we all have. CBD doesn't actually, it has a very, very low affinity towards the CB1 and CB2 receptors. In fact, it has major affinity towards these receptors, which include 5-HT1A, TRPV1, GPR55, FAH, adenosine receptor, PPAR, sigma 1, glycine. And these together have the main therapeutic function for CBD rather than the CB1 receptors and CB2 receptors. The CBD is approved for a variety of indications as of now, and how it works is by these receptors. The FAAH inhibition. FAAH is the molecule which was causing the degradation of anandamide. Now, what the CBD does is it inhibits the FAAH and interestingly increases the natural anandamide levels in the body. So this is how CBD is used in anxiety and depression and a lot of pain and other neuromodulation. 5-HT1A anxiolytic antidepressant, TRPV1 pain inflammation, PPAR gene expression metabolism. So all these are the effects of a cannabidiol. Going to the THC, what happens when we see a patient who is taking cannabis on a daily basis? How how has he become a patient? What happened to his brain? Basically, what THC does when it is taken in a large quantity and for a regular long period, it hijacks the whole endocannabinoid system. What I mean by hijacking is the CB1 and CB2 receptors are already present in PFC, prefrontal cortex, amygdala, hippocampus. But because of the large quantity of THC, all these areas starts to malfunction. There is problem in executive function, decision making, attention, working memory, which precisely we understand as an amotivational syndrome. When we see a patient who is using cannabis for a very long time, we know that he doesn't have motivation to do anything. This is why the people who use cannabis for a very long time and in large quantities, they have a amotivation syndrome. Similarly, they are stoned. Typically, the word used for large cannabis user is stoned because it malfunctions the amygdala, which handles the fear, emotions, anxiety. So basically, all the symptoms are malfunctioned when THC is consumed in a very large quantity. However, when the CBD is consumed in a large quantity, it doesn't hijack because it doesn't work on CB1 and CB2 receptors. But here is the precise difference between THC and CBD when it is consumed externally. The intoxication is present in THC because it works in CB1 receptors and CB2 receptors, which are located in CNS, but CBD doesn't work in these two receptors, so the intoxication doesn't happen. There is abuse potential because of a certain euphoric feeling which a person can get with THC. In high dosage, the anxiety and psychosis can increase with THC, but the same can reduce with CBD because of its anxiolytic effects. Cognition is impaired when consumed in large quantities by THC. The sleep is THC causes sedation and therefore it is being utilized in a lot of insomnia patients. The reward system, THC can cause euphoria. So here we understand that THC and CBD, even though they are from the same plant, THC has a high risk of psychosis. That is where patients comes to us because of the increase in dopamine levels in mesolimbic pathway. Psychosis risk, anxiety risk, memory impairment, all of this happens with THC if it is consumed for large quantity and for a very large period because of the mesolimbic dopamine. However, nothing of this is possible with CBD overuse also. So overall, we now have understood how the endocannabinoid system is very crucial and central to overall mental well-being. Not just mental well-being, it affects a large part of our day-to-day functioning, but it is very underutilized in therapeutic modalities. Now we let us see how these THC and CBD, the whole endocannabinoid system, plays a role in day-to-day patients what we see in our OPDs. In anxiety, it works with fear extinction. In depression, the stress resilience. Through in PTSD, through memory reconsolidation, the by hippocampus. In addiction, reward learning. Schizophrenia, dopamine modulation. We just saw THC can increase psychosis risk, but you all will be amazed to see that CBD is being approved for psychosis management. CBD is being approved for psychosis management, and THC can cause psychosis. In OCD, through habit circuitry, autism, social behavior improvement, sleep disorder, circadian rhythm regulation. How I developed interest in this endocannabinoid and cannabis use is because of one of my patient who was a 14-year-old, very fat boy, 120 and 130 kilograms, very aggressive. The parents brought me and I asked कि आप 13 साल तक कहाँ थे? This child you cannot manage at home. They said कि सर 5 साल से वो बहुत अच्छा था क्योंकि हमारे एक डॉक्टर की दवाई चल रही थी कैनबिस वाली। जैसे ही वो दवाई बंद हुई, उसके बाद इसके साथ स्कूल टीचर ने इसको एक बाथरूम में बंद कर दिया 2 घंटे तक क्योंकि ये स्कूल में मस्ती कर रहा था। And after that, he got kind of a PTSD and then went into depression and then started fearing everything outside. And that's the time they brought him to me, and where I understood that cannabis and CBD are actually in the market and doing good. Let us quickly see the pharmacokinetics, because if you're going to use the molecule, you should be knowing what effects it can have in the body. There are various routes: oral, sublingual, inhaled. The oral route is the slowest onset and the absorption is very variable. However, sublingual use is faster than oral, and the absorption is still variable. Inhaled, like most of our patients, it is rapid onset and have a psychiatric relevance. Very important thing that the fatty meal can increase the absorption of the cannabis, and that is the major reason why in most of the studies that the effects of the CBD trial has been inconsistent because of the absorption level changes. The oral bioavailability is just 6 to 10%. It can peak in 2 to 5 hours, and it will be eliminated from the body from in 18 to 32 hours. When we talk about sublingual dosing, it's even faster onset and the half life is almost similar. Inhaled is better bioavailability and the onset is within minutes. Those who use cannabis through smoked form, they can feel the effects within the few minutes. Intranasal is very experimental, has not been approved or not been released in any of the formulations as of yet. So what we do right now for our patients is we advise them to take sublingual cannabis oil, and the oral is something which comes as a gummies or a cookie, but the absorption is so variable that a high can happen at any random point which the patient will not be aware of. Regarding drug interactions, it is not that the cannabis or CBD is free of any drug interactions. CBD is metabolized by cytochrome 2C19 and cytochrome 3A4, and thus it can increase the exposure of clobazam and can cause increase in transaminase levels with valproate. So if you're prescribing, these are just the two of the indications where we need to be careful if the patient is taking these two molecules. Safety and tolerability, it's considered very safe. None of my patients have reported any side effects apart from some dizziness. Diarrhea is said to be another common side effect, but I have never found in any of my patients. Reduced appetite, somnolence are very variable. So safety wise, it is one of the safest molecule, I would say, when we are treating a patient who having anxiety, which is not being treated by your first line management molecules. And that is the time when the patients are also willing to try other forms of therapies. And a lot of times patients nowadays want a holistic kind of an approach. They would ask you, sir, allopathic के अलावा और कुछ है क्या? That is the time this is the most accepted route. The actual question, does CBD actually work? Why is it not FDA approved, or why it is not in the mainstream as of yet? Let us see the latest clinical findings in the journals, how it is published right now. So this was published in Nature in 2022, where the high cannabidiol treatment in anxiety was done in open label phase 2 clinical trial. In this, they had given 4 weeks of 1 ml CBD, which is sublingual solution of 10 around 10 milligram per ml, with 0.23 milligram per ml THC. So here it is important that this trial had not just taken CBD oil, but it had also taken THC combination with the CBD oil, and where they have found that clinically significant treatment response, more than 15%, is achieved within 1 week for most patients. And by cumulative frequency of treatment is 100% by week 3. So almost 100% patients of anxiety responded to CBD plus THC, and this is in Nature, which is one of the highest ranked journals in psychiatry. Then this is about the paper in Asian Journal of Psychiatry published in 2024. The study was done in India, and here as well they have done a double blind and RCT. They have identified there's a HAM-A score difference at the end of the treatment was better than the placebo, and overall the therapeutic effects were much better than the placebo. So it is a phase 3 trial, they are saying, which is being done in India. The research, earlier research in 2011 by Kripa et al. Was about social anxiety, wherein a bolus dose of cannabis CBD was given to people who were going to do public speaking. Their fMRI studies were done, and it was found that the limbic system was less activated after a person has consumed CBD, and that is why the acute anxiolytic effects were consistently demonstrated in people who were using CBD. Over the time, RCTs have been done, meta-analysis have been done, and one of the meta-analysis, and this is a summary of most of the meta-analysis in different forms of anxiety. If we see that all forms, from experimental anxiety, which was in animal model, social anxiety, healthy volunteers, clinical anxiety, the improvement has been consistently demonstrated in the meta-analysis. Only thing is the sample size is small to moderate, and that is the reason it is something which requires a large scale RCTs to be in the mainstream of prescribing. This is another journal, Lancet Psychiatry, a latest 2026 paper, which is checking the efficacy and safety of cannabinoids for the treatment of mental disorders and substance use disorder. They are saying that their meta-analysis revealed that a combination of CBD and THC reduced cannabis withdrawal symptom. So till now we had different molecules to support people having alcohol, opioids, cocaine. But when a patient who had a dependence on cannabis comes, we were thinking what to replace it with. So here is the Lancet answering our question, saying that a combination of CBD plus THC is where it has found reduced cannabis withdrawal symptom. Not just that, in fact, it has also shown improvement in tic disorder, Tourette disorder, and autism spectrum disorder. This is a meta-analysis which is published in Lancet Psychiatry, confirming that the use of CBD plus THC has shown significant improvement in these disorders. This is another trial which was done in autism spectrum disorder. Why I have included this one is again that it is not just plain CBD they have used, but they have used CBD plus THC in a ratio of 20:1, and they have successfully found improvements in autistic behaviors of children. So, autism improvements in irritability, aggression, sleep, all of these are found. PTSD, fear extinction, memory reconciliation, nightmares. In addiction of cannabis, opioids, nicotine, there are positive signs of usage of CBD plus THC. Like I said, that a lot of research has been happening about CBD in psychosis, and it's interesting to know that in 2012 itself, Leuke had done a trial wherein CBD was found superior or equivalent to use of amisulpride in reducing the positive symptoms of schizophrenia. McGarry had done an add-on trial with clozapine in treatment-resistant schizophrenia. The result was found to be mixed. There are a lot of ongoing trials of psychosis and use of CBD. The results are expected very soon. Overall, when we see the disorders where you can use CBD are the anxiety disorders with moderate evidence, psychosis, substance use. Depression, however, has not made to the list. The primary reason is because there has been no RCTs done in depression till now. Whatever has been done is undervalued, underrated, and the absorption of the cannabis was so variable that the results were not consistent. The further studies which are ongoing is for schizophrenia and psychosis, which are step promote, step assist, and early psychosis CBD augmentation. Like I said, in depression, the RCT's evidence has been very low. There has been not a single RCT which has been done, large scale RCT on depression. For other conditions, there has been the evidences are not up to the mark till now. But anxiety, depression, autism, substance use disorder, CBD is one of the treatment options which we can have in our armamentarium when we are treating such patients. Now talking about the dose. Most of the studies mention a cannabidiol dose of 300 to 600 milligram per day for improving anxiety symptoms. Typically, what is available right now for the from various manufacturers is 100 milligram per ml for Dravet syndrome resistant epilepsy, which is being used. However, in anxiety, we will need to go much higher, which is 300 to 600. This also reminds me of another thing, how another molecule which has been used in epilepsy, such as valproate, oxcarbamazepine, lamotrigine, which are core molecules for psychiatry. And how do we always need higher dose than such molecules which control epilepsy? In psychosis, the dose studied is more than 600. Of course, in epilepsy, is 10 to 20. Epilepsy is an FDA approved treatment indication for CBD. One important thing that the OTC products, whatever you will find that people say, I am using this from Amazon or through a medical store, the concentration is being found to be 10 to 50 milligrams. And moreover, the ratio of THC and CBD is very much variable. So it's always important to have a medical grade product when we are prescribing CBD and THC. This brings me to the end of the presentation. That the science is fascinating. This is the molecule we all want, a magic molecule. But the real test is what happens when it enters your clinic. These are the references, and we can have some questions if you want to have.
Hello. So wonderful presentation. I have a question, sir. If you factor in the cost of treatment using cannabis, can you tell me about the
It is
treatment cost?
right now, it is a costly treatment, I can say. But when you don't find any other solution, and there are people who generally want to take organic supplements or organic route of treatment, and that is wherein the cannabis can be used. But yeah, I would say it's not as easy, as cheap as other escitalopram. But of course, you will go to CBD only when you've not gained a response from the first line treatment molecules.
I feel there is a significant
Very
cost difference.
significant. Very
Like it's
significant.
very expensive, I guess.
Yeah, it's very costly. But again, the patients who have not been benefited with any of these, we can give it a choice. And of course, it will depend on the person, the patient, if he wants to spend. Of course, it's a long treatment, it's expensive, but the cost is something which we have to give a choice to the patient.
One more question. You mentioned that you had a patient who was taking since 5 years. He was prescribed. I just want to know for my information, was it prescribed by a psychiatrist?
No, it was
That
not.
shows that we are far behind.
We are very far behind actually. This doctor, he was not even a psychiatrist, not even a allopathic doctor. And what amazed me was the number of autistic kids who go to him for treatment. And people are happy with his treatment. That made me understand that okay, something is working. Then I realized that Ayush Ministry has approved this for clinical usage. And that is why most of the Ayurvedic doctors were using it. And later when I myself saw the kind of varieties they have in Thailand, it's actually fascinating to see these molecules having so many different roles, and we are not using it for any other purpose. And then I started using it in a lot of patients, and a lot of patients who, especially those who have substance use, cannabis use disorder problem. I have a patient who is from Australia. She takes cannabis every night, and she had very small amount of those CBD and plus THC oil, and said, "Ki sir, this is amazing. I would like to use it for like all my life because the kind of high I got was much better than what I used to get with smoking 2 to 3 joints." So I am very, very positive about the CBD use, THC use in cannabis use disorder, where we could not do anything. Take it in a way of harm reduction, how we do in opioids. I'm not saying that we will take him out of addiction by giving this molecule, but it's kind of a harm reduction which will help patient a lot.
Thank you, Dr. Prakhar. That was a very comprehensive and well detailed presentation. I'm happy to see that some kind of new advancements are finally coming into psychiatry, although we are a little slow to adapt to them. And what particularly excites me about CBD is its use in regular cannabis users. Because as you mentioned, in most of the researches that I've done so far, it has little to, let's say, moderate effect on many of the psychiatric disorders that you have mentioned. But in cannabis patients, I've seen personally in my clinical experience, it has been used as a good substitute in terms of harm reduction. But what do you think is the role when it comes to cannabis-induced anxiety or cannabis-induced psychotic patients? Does it really help in these kind of cases as well?
These cases are the red flags where we should not use THC at least, but definitely use CBD because CBD causes anxiolysis and also streamlines the effect of mesolimbic dopamine, which is increased by cannabis use. So these are the red flag patients where THC should never be used, but CBD should be used because these will counteract the effects of THC what they are having. So if you remember, there was a slide which showed how THC and CBD are different. CBD provides improvement in psychosis and anxiety, and it is very safe to be used in people who have cannabis-induced psychosis.
Thank you. We'll take questions from the audience if anybody has one. Yes, please.
Two questions actually. So first is we cannot prescribe cross-pathy, right? So if it is an Ayush certified medicine, I think we cannot officially prescribe it in our papers.
So there is a
So do we
Yeah, yeah.
go for the supplement approved thing or not?
no.
How do we
It
prescribe
is a
it?
kind of a loophole, I would say.
Hmm.
The regulation says registered medical practitioner can prescribe, and registered medical
Is that
practitioner.
specifically for CBD?
Yes. So
THC?
CBD has been moved to Schedule E of Drugs and Cosmetic Act, and Schedule E, RMP can prescribe, and that is where till now we were not having. In fact, CBD was also not available since 2 years back, but now CBD is also available in allopathic formulations. So similarly, the THC content of the drug has been moved to Schedule E in 2022. And that is where the whole definition changes, and an RMP can prescribe. Although in Schedule E, the person will need valid prescription, like in any other psychiatric drug.
Okay, and as the FDA has a stand on this, does IPS also have a stand on
I
CBD
don't
use?
think IPS or FDA has given any statement about the the use of this molecule. FDA, as in US FDA, you are saying?
Yes.
US FDA has till now not approved for any of these indications in psychiatry.
Okay.
Of course, the
Seizure and
reason,
all,
sorry,
seizure and all, it is not approved.
seizure is approved, but in psychiatry, any of the indications, and the reasons is what we discussed, how the sample size and the way the trials have been designed is in such a way that the overall consistent effects have not come. Even in the Lancet paper, you would see they have said that it has been found useful in these few indications, but the depression RCTs have not been done. They're not adequately powered. There have been studies for anxiety also, but the sample size is very small. Like when I was doing the research, the maximum I saw a sample of 220, and most of were less than 50. Cumulatively in all over world, the meta-analysis, however, whatever is published, it's only 2,200 patients.
So asking from safety perspective of our own practice, looking from the lens of litigation, lawsuits, or policies, is there anything we should be careful about to for the safety of our?
No, I have been using it for quite a time. It doesn't. I have checked that it doesn't come under NDPS also. NDPS also doesn't call it as a narcotic drug, and you cannot prescribe it. Even it is approved as a prescription only molecule under Schedule E. So it is
So we
kind
can
of,
even have it in our self-dispensing clinic.
yes, you can have it and dispense it for patients, but not for personal use.
Thank you. Thank you so much.
Thank you so much, sir. It was a very insightful presentation. Thank you, chairpersons. Now, may I request the chairpersons to please facilitate the speaker?